Hi, and welcome to part 7 of Afib. Today we're going to talk about how to assess stroke risk in your Afib patient. I mentioned earlier that there's a high prevalence of stroke in patients who have Afib, so it's paramount to try and reduce the risk. In other words, one of your primary goals is to prevent thromboembolic events secondary to Afib. Now, the most common patient presentation you're going to see in regards to Afib is the patient who's receiving rate control. And since you're going to need to assess the stroke risk for any patient with rate-controlled Afib, you're going to need to calculate a CHADS-2 score. And the CHADS-2 is a 6-point scoring system that gives you 1 point for CHF, it gives you 1 point for hypertension, 1 point for age greater than 75, 1 point for a history of diabetes, and 2 points for a history of stroke or TIA. A score of 0 is going to indicate the patient's at low risk for stroke. A score of 1 puts the patient at intermediate risk, and 2 or more points means that the patient has a really high risk of stroke. In clinical practice, you may come across the CHADS-VASc score also, which in some cases may be used instead of the CHADS-2. The big difference is that you have more point possibilities with the CHADS-VASc. So it will give you 2 points if your age is greater than 75, whereas with the CHADS, you had 1 point for greater than 75. And with CHADS-VASc, it gives you a point for being younger, so between 65 to 74. And there's no lower point values for lower age there for CHADS-2. Diabetes are the same. CHADS-VASc assigns you 1 point if you're female. A slight difference between CHADS and the CHADS-VASc with heart failure is that with CHADS-VASc you get a point if you have a patient with left ventricular ejection fraction less than 40%, but without heart failure symptoms. Another difference is that CHADS-VASc assigns 2 points for a history of systemic embolism. So this means a clot that embolizes and affects organs with large vascular supplies like the lungs, coronary arteries, spleen, liver, bowel, peripheral vasculature. And finally, the CHADS-VASc assigns 1 point for a history of vascular disease, and the CHADS-2 doesn't. Now, proponents of the scoring system are going to note that it's more sensitive for determining stroke risk in patients who are at low or intermediate risk, according to the CHADS-2. But the CHADS-VASc hasn't been proven superior to the CHADS-2, and because ACCP or CHEST advocate the use of CHADS-2, that's what we'll be using in class. Now let's say that you're seeing a 55-year-old male receiving rate control for his Afib. He doesn't have a history of CHF, hypertension, diabetes, or stroke. So according to CHADS-2, he has a score of 0 and is at low risk, which means that he doesn't necessarily need to receive any antithrombotic agents. But what if his age was actually listed incorrectly on the chart and it turns out he was actually 75 years old? In that case, now he has a CHADS-2 of 1, which means he needs either anticoagulation or the combination of aspirin plus Clopidogrel. But now let's say that you meet a sassy 81-year-old lady named Mabel, who in addition to Afib has a history of diabetes. Her CHADS-2 is going to equal 2 points, 1 point for her age and 1 point for the diabetes, which is going to put her at high risk for stroke, which means that she needs oral anticoagulation. Now, in regards to oral anticoagulation choices, dabigatran may be preferred over warfarin for non-valvular Afib, but we'll talk more about this later. Or she could be a candidate to receive either apixaban or rivaroxaban, assuming she has non-valvular Afib. So as an aside, if a patient has valvular Afib, they'll need warfarin since none of the other agents are currently approved for this indication. Now, if she's unable or unwilling to take oral anticoagulation for reasons other than bleed risk, she'll need to take aspirin and Clopidogrel in combination. It's worth noting here that one of the primary reasons that patients don't receive appropriate anticoagulation is because of the concern regarding bleed risk. If bleeding is a concern, you can calculate a bleed risk score known as the HAS-BLED. You need to keep in mind, though, that this scoring system only provides a modest risk prediction and should only be used as guidance. With the HAS-BLED system, you get 1 point for hypertension, you get 1 point each for either abnormal renal or liver function. So you can have up to 2 points there. You get 1 point for history of stroke, 1 point for a history of bleeding, 1 point for labile INR history, 1 point for elderly, age greater than 65, and 1 point each if they are taking either antiplatelets or NSAIDs, or if they have a history of alcohol abuse. So you have a total point scale of 9 points. A 0 score is going to indicate low risk. A score of 1 to 2 is a moderate risk of bleed, and a score of greater than 3 is high risk. It's only modest prediction for bleeding risk. So if you have a patient that has 3 points and needs anticoagulation, I don't know that I would necessarily withhold anticoagulation in that case. I would just follow up with close monitoring. But you want to use clinical judgment. Of course, if your patient with a bleed risk is a professional knife juggler doesn't want to give it up, anticoagulation may not be a safe choice. So again, you just want to use clinical judgment in these cases, and just because they may have a score of greater than 3 on a HAS-BLED scale, it doesn't mean you're going to withhold anticoagulation. Just take the clinical picture into consideration when you make your decisions. It's also important to note that the combination of aspirin and Clopidogrel carry the same bleeding risk as oral anticoagulation does. So if you're really concerned about a patient's bleed risk, don't start this combination in lieu of oral anticoagulation because the patient's going to be at just as much risk. All right, so let's reset a bit and say that your patient has a CHADS 2 score of 1. Here you can consider aspirin 81 to 325 a day plus Clopidogrel 75 a day is your primary option, but you can initiate oral anticoagulation if you want. If you're concerned about the risk of bleeding, you can just give aspirin alone without the Clopidogrel. I mentioned that the combination has the same bleed risk as oral anticoagulation, but where did this info come from? Well, if we follow the line to here, we're going to find a trial called Atrial Fibrillation Clopidogrel Trial with irbesartan for prevention of vascular events, but some just call it the active trial. So in this trial, patients with Afib with a CHADS 2 of 1 were randomized to either receive aspirin 81 milligrams daily plus Clopidogrel 75 milligrams daily, which was the active arm, or they would receive Warfarin alone, which is the active W arm, or they would receive aspirin alone, which is the active A arm. Now this arm is reserved for patients who either weren't a candidate for oral anticoagulation or for those who refused Warfarin. Now in this trial, they found that the combination of aspirin plus Clopidogrel was superior to aspirin alone for prevention of strokes, but the combination was inferior to Warfarin in preventing strokes. So combo is better than aspirin alone, but not as good as Warfarin alone. Now there's no difference in bleed risk between the active and the active W arm. Equal bleed risk between Warfarin and combination aspirin plus Clopidogrel. And there was a significant increase in bleed risk when you compare the active group versus active A. So the moral of the story again is that dual antiplatelet therapy carries the same bleeding risk as oral anticoagulation. And if a patient has high bleeding risk and you don't want to start anticoagulation, then the combination aspirin plus Clopidogrel is not going to be a good option in them either, because they're going to have just as high risk of bleed. So again, what if your patient's CHADS 2 is 2 or more? In this case, oral anticoagulation is definitely going to be indicated. If the patient has a history of any kind of valvular disorder or valve replacement, it means they have valvular Afib and you're going to need to choose Warfarin. I won't cover the specifics on the anticoagulants in this lecture, since you already have that information from Dr. Odom, but if your patient doesn't have valvular Afib, also called non-valvular Afib, you can choose either dabigatran, apixaban, rivaroxaban, or just good old Warfarin. There's not necessarily a right or wrong answer regarding which agent to pick, as long as the patient doesn't have a specific contraindication to one agent, like renal or hepatic failure. But with that being said, there are a few considerations you can keep in mind to help guide your choice. First of all, what are the advantages of the new oral anticoagulants versus Warfarin? Well, you're able to use fixed dosing with all 3 new agents, and you remove the need of frequent monitoring. There's a lack of food-drug interactions like you see with Warfarin, and you'll get a good, predictable anticoagulant effect, something that can be really difficult with Warfarin, especially in patients with certain genetic polymorphisms. So what are some disadvantages of the new anticoagulants? There are plenty, and reversibility is a big one. There aren't any specific reversal agents for the new oral anticoagulants like there are for Warfarin, so this can be a big problem in the event of overdose. If they have a high stroke risk combined with high bleed risk, if they need urgent surgery, or if they have new onset renal or hepatic failure, where the half-life of these drugs can become significantly prolonged. In addition, Warfarin isn't renally eliminated, so no dosing adjustments needed like it is with the new agents, which means they're not appropriate for use in patients with unstable renal function. Now, although dabigatran can be technically used if there's hepatic failure, it's recommended to shy away from it if patients do have hepatic failure, since there's an increased risk of hepatorenal syndrome, which leads to subsequent renal failure. Now finally, although drug-drug interactions are pretty common with Warfarin, very few drugs are considered absolutely contraindicated, since the patient's INR can be closely monitored, and the dose can be adjusted if it's needed. Now, several drug interactions are possible with the new anticoagulants as well, but there's really no way to directly monitor the impact since they don't alter the INR or APTT reliably, at least not reliably enough to assess how super therapeutic the patient actually is. And regarding dabigatran, it's recommended to avoid using it if the patient's taking amiodarone, verapamil, dronedarone, or quinidine, because if you have a patient AFib, there's a decent chance they'll be on one of these drugs. And finally, dabigatran needs an acidic environment to work, but it causes a lot of dyspepsia, which means that PPIs and H2RAs may be commonly used to help with symptoms. The problem is these drugs are going to raise the pH, which is going to make the environment less acidic, and which is ultimately going to make that environment less hospitable for the dabigatran to actually work. So the dabigatran needs an acidic environment to work. PPIs and H2RAs are going to decrease the acidity, so there's a decent chance that the dabigatran is not going to work in that case. It's not a good combo. Okay, well this brings us to the end of your Afib lecture. I hope I've been able to describe management clearly enough, but if not, please bring your questions with you to class. And we'll work through any muddy points. We'll try to work through some classes in case, and hopefully get you guys ready for your exam. Thank you. Hampton out.